Good afternoon, good evening, and a very early morning to some. Big Axiom welcome. Thank you to Dr. Borghaei, Dr. Tolaney, and Dr. Grivas, who will be joining us shortly for joining us this afternoon. Axiom as a think tank strives to narrow the knowledge gap between academic and community clinicians. As with every think tank discussions, we'll focus on what is practice changing, keeping the patient in mind. Now off to Princeton, to John to get us all started.
Hi, and welcome to everyone who's joined, and doctors, thank you again so much. So some of the pretense for this discussion is we know this past summer, hard to believe summer is almost over already, but there was a lot of discussion and debate at a recent FDA ODAC around the contribution of parts when it comes to, we think about peri-operative treatment. So what is the contribution from the neoadjuvant treatment? And then what is the contribution from the adjuvant treatment post-surgical setting? Obviously, post-ESMO, we saw a lot of exciting data from the bladder side, the Niagara trial, looking at peri-operative treatment, as well as some of the long-term data from the Keynote 522 study in breast cancer, and always kind of the Aegean study, seeing some of that additional data there following ESMO. So we'll open it up to our physicians here, and we'll start off simply. We'll go alphabetically, let them introduce themselves, and Dr. Borghaei, please go ahead.
Hello, everyone. I'm Hossein Borghaei. I'm a thoracic medical oncologist at Fox Chase Cancer Center in Philadelphia. Glad to be with you.
And I'm Sara Tolaney. I'm a breast medical oncologist at Dana-Farber Cancer Institute in Boston, and also glad to join today.
Excellent. Thank you both so much. And my colleague Sana here will be kind of helping us manage some of the Q&A. So as you know, for those who are attending the session live, feel free to drop questions into the Q&A at the bottom. So why don't we start off? I'd be kind of curious to think about, how are each of you, whether that be in the thoracic setting, Dr. Borghaei, or within the various sections of breast cancer, Dr. Tolaney, how are you starting to think about the management of all of these new therapies that you've been using in the metastatic setting, moving up to that peri-operative? And how is that going to impact, and how is that impacting some of your current clinical care?
Okay. Do you want?
Go ahead.
Sure. Go right ahead, Dr. Borghaei.
All right. So obviously in the world of lung cancer, I think this is welcome news. Simply put, for patients with early stage non-small cell lung cancer, or outcomes for our patients post-surgery really have not been that great. A couple of decades ago, we saw the results of the studies where introduction of 4 cycles of platinum doublet chemo after surgery led to improvement in overall survival of a group of patients who've had surgical resection. But when you look at sort of stage by stage overall survival after surgical resection, a curative intent treatment, survival of patients with lung cancer wasn't really good. So moving chemotherapy, immunotherapy to an earlier stage allows us, and the hope is that it will improve the overall survival of patients with early stage lung cancer. And I realize that, that's a lofty goal in lung cancer, but if you're talking about the resectable disease, treating patients with curative intent, I think we all want to see some level of overall survival advantage. Data seems to suggest that in an early stage disease, majority of lung cancer tumors tend to be a little bit more sensitive to the effects of checkpoint inhibitors compared to what we see in a metastatic setting. And the introduction of this initially neoadjuvant treatment with checkmate 816 and subsequently all the peri-operative studies, some of which you referred to, has indicated that at least the rates of pathologic complete responses are higher in a patient population that gets chemotherapy, immunotherapy. Event-free survival seems to be better, although the comparator for all of these studies have been chemotherapy. And the issue of how to solve this problem of what is a contribution of neoadjuvant and adjuvant treatment remains one for which we don't really have a clear answer at this point. In lung cancer, what we're seeing is that overall, the event-free survival seems to favor patients who have had a complete pathologic response And at least based on some of the studies, including agent that you mentioned, ctDNA negativity seems to predict for better outcome over the period of time that we have been able to follow patients who participated in the study. As to whether everybody after surgery needs to get additional, 9 months or 12 months of immunotherapy, that remains a question for which we don't have an answer. And that has led to at least a couple of proposals from cooperative groups to try to address the patient population with a complete pathologic response or those without a complete pathologic response in a randomized fashion to see if additional treatments, whether combinations or single agent, would contribute to improvement, again, hopefully to the overall survival. I think to some extent, I obviously agree with our colleagues at the FDA. What are we trying to accomplish in this perioperative surgical world? To simply say that anybody after surgery should get additional months of treatment for treatments that are both financially and otherwise carry toxicities, and the potential toxicity of single agent IO cannot be ignored. I think it's difficult. And as a clinician, if I'm faced with somebody who's had a complete pathologic response, is doing good and returning to normal life, to subject them to additional treatments that, again, could cause pneumonitis and other issues, it's a difficult question to answer if a patient directly says, well, what am I going to get out of this? What are you hoping to accomplish? So at an individual patient level, that question becomes difficult to answer. And the way I'm answering it now is that if you follow the studies that have been published and discussed, the protocol calls for additional treatment, which is not really a good way of wanting to decide things. So I think we're left with a little of an unknown, and we're hoping that additional trials will lead to some clarity, at least in the world of lung cancer.
Yeah. And what are you seeing, Dr. Tolaney, when it comes to breast cancer within, TNBC at the start? And I know there's future studies in other segments as well.
Yeah, I mean, it's a challenge. In breast cancer, we have data from our big registration trial, Keynote 522, which had taken patients with stage 2, 3 triple negative disease, gave them chemo with or without pembro, pre-op, took them to surgery, and then after surgery, the people who got pembro just continued the pembro so that they got a total of a year of therapy. And what we saw was that adding pembro to chemo pre-op improved pathologic complete response rates. It improved event-free survival. And now at ESMO, we saw it improved overall survival. So clearly, utilizing pembro and chemo in our minds is standard of care. But I think the question that just got brought up is this contribution of phase question is, well, what drove the EFS OS? Was it the pre-op portion they got? Was that enough? Would that have driven this long-term outcome benefit? Or did they really need to continue on that extra pembro after surgery, which in that design was not adapted based on response to therapy, which is not how we currently practice. It was designed in an era where we didn't know we needed to adapt treatment based on response. And so, I think we're struggling now with what do we do post-surgery? And, we also in the breast world have a cooperative group trial trying to address the question of, do you need to continue that immunotherapy in the adjuvant setting? But it's complicated because the trial that ended up getting designed was specifically for people who achieved PCR and said, okay, we get a really good outcome. We don't know that you really need to continue on that pembro, because in fact, when you look at the Keynote 522 data, as they just presented at ESMO, and you look at the overall survival data, people who had PCR had, in essence, the same OS, about a 95% OS. They did really well. And so it made us wonder, do they really need that adjuvant portion? It's kind of easy to de-escalate a group of patients who has very good outcome. But it takes 2,000 patients to address this in a non-inferiority design. It's going to take us many, many years. The treatment paradigms are going to change. And so it's not easy to undo, in essence, what's been done. And same in the residual disease population, you'll say, hey, these people are high risk. Even if you look at the OS data in 522, still about 30% of people were dying from their disease, even if they got pembro, right? So they did better with pembro, but outcomes aren't great. And so it's hard to pull back from a group of patients that aren't doing that well. And so we don't have a clear path to get rid of the adjuvant portion of pembro in the residual disease population, because it's just a very hard study to do. And so I think the FDA stance on this contribution of phase is an important one, because once it's done, it is hard to undo. But the problem is, in the breast world, it's not, we are continuing to practice as if pembro is standard of care in everyone, and future registration trials are designed with it being standard of care in the adjuvant setting. So we're not undoing it, if you will, very easily. It's going to continue. And so while the new FDA guidance is to develop studies that, will address contribution of phase, I think it's important. But I also think the feasibility of this is not so easy. I mean, to be honest, I understand why Merck did the study they did, to take people getting pre-op pembro and then say, hey, I'm going to randomize you at the time of surgery to address contribution of phase, is really hard, because we deal with PCR patients differently than residual disease patients. Many of them are going to drop off because they develop tox to IO in the pre-op setting. They're not even going to be eligible for that second randomization. And then you're doing multiple arms of randomization. Honestly, it would take several thousands of patients to do these kinds of trials. And is it feasible in a timely manner? In the breast world, it's going to be tough, to be honest. So I definitely understand the stance, but I'm also curious to see how this practically will roll out as future studies are designed.
Yeah, I wonder, and kind of curious to hear both of your perspectives on this, of obviously, looking for patients who have PCR versus those who don't, and understanding, is there some differences? And Dr. Grivas is thank you, Dr. Grivas, for being able to join. I know you had a last minute patient kind of come in, and we really just kicked off the conversation where we're talking about the peri-operative treatment setting. Obviously, Niagara being kind of most relevant to you in that case, and the question that I'm bringing forward, kind of curious for you to chime in on this as well. When we think about understanding the contribution of parts for the neoadjuvant and the adjuvant setting, I wonder, is there a role potentially for ctDNA kind of integration of tracking and monitoring? Maybe there's kind of a de-escalation approach or some hybrid between, is that adjuvant treatment setting kind of fully needed?
Yeah, a lot to unpack here. Can you hear me okay? Just want to confirm.
Yes, we can hear you just fine.
Okay,
Perfect.
Great. Sorry for the delay. Try to, address an acute issue in clinic with the nursing team. I'm sure everybody can understand. So thanks so much for having me today. And I see great colleagues and friends here in the virtual room. I can comment a little bit, and I want to hear what the colleagues have to say. Number one, that's a complicated answer and a lot to unpack, but I'll try to do my best with bullet points. So number one, the design of the Niagara trial, and just for the non-GU colleagues, this was a neoadjuvant/adjuvant perioperative trial, similar to what, Sara, we have seen in breast cancer, Keynote 522, if I remember the number, with chemo pembro. I'm learning from you all the time. And that trial had this neoadjuvant component of Gemcis neoadjuvant plus durvalumab versus Gemcis alone in the neoadjuvant setting. And then there was a given plan for durvalumab adjuvantly up to 8 monthly doses, regardless of the pathologic stage. So there was no adaptation or path stage adapted approach. It was kind of a sandwich approach, we'll say. That trial, we can discuss nuances if you want in detail, met the primary endpoint of event-free survival. There was a hazard ratio 0.68 for EFS, met the secondary endpoint of OS, 0.75 hazard ratio for overall survival. Obviously, this can be confounded, impacted by what the control group received in the adjuvant setting, and of course, in metastatic setting, this can definitely impact the performance of the control group in EFS and OS. With that, and the nuance is that the trial finished accrual, the Niagara trial, about a month before the adjuvant nivolumab got approved by the FDA in the US, and subsequently the EMA approved nivolumab in Europe. So the take home is that barely any patient, if any, received adjuvant immunotherapy in the control group. So that may have influenced the results of the study. So the big question, I had the honor and opportunity to be the discussant at ESMO in the Presidential Symposium, and one of the points I raised was similar with what Dr. Koch raised for the Keynote 522, which is individual contribution of the neoadjuvant phase and the adjuvant phase. We cannot tease that apart based on the design of Niagara or Keynote 522. It's kind of, again, a sandwich approach. Can we use any hints from the trial data to help us understand that? From the Niagara trial, is still too early because we have not seen data based on the path stage yet. So this was part of my wish list that I had in my discussion to the study team to, in the future, give us some data about, path CR, path down staging, pathologic residual muscle invasive disease, how these people do, just to get a flavor of the prognosis. Of course, will be ad hoc and exploratory analysis, but will be helpful. And we saw that analysis in the Keynote 522. And if I remember the numbers, I think the hazard ratio for the path CR, Sarah, correct me if I'm wrong, I think it was 0.69 with a wide confidence interval or crossing one. So there's still open question in breast cancer 8 years later, follow up about the path CR. So I don't think we're close to answer this question in bladder cancer yet. For the moment, I think we take it or leave it, and we're probably going to overtreat some patients, yes. And in that, with that caveat, with the absence of a reliable biomarker, I would probably take that a peri-operative approach and use durvalumab before and after. Can ctDNA help us in that regard? In the future, possibly yes. We need data. We saw data from the Tombola trial at ESMO. Interesting data. We're waiting for a few more studies. The modern trial with Alliance in the US and the InVigor-011 I think it's a global trial to answer the ctDNA predictive value clinical utility question, which is still open, I think, in this research. So we're going to have bits and pieces of data to try to answer. I don't think today I'm ready to make a decision based on path stage or ctDNA, at least in bladder cancer for the adjuvant component. I'm going to overtreat patients, that's a caveat, but I will probably take the trial design as it is.
Yeah, curious your thoughts across the board, and especially yours, Dr. Grivas, kind of as you're mentioning it. When you think about the design of future studies in this peri-operative setting, and then based on what the FDA's guidance around trying to design these adaptive, more novel, potentially clinical studies that let us understand the contribution of parts. Is there any ethical concerns that you guys might have as clinicians around some of these, some patients receiving neoadjuvant, some receiving adjuvant, and then maybe some receiving both?
I mean, I'm happy to think about that a little bit too. I will say that I think it's hard. I mean, I think right now it is certainly standard, as Dr. Grivas noted, I too am just giving everyone the whole year of checkpoint inhibition, giving it pre-op and continuing an adjuvant, even though I don't really know if they need the adjuvant component. I will say in breast cancer, at least, we do have some data to suggest that the adjuvant component may not be so necessary. We have a trial from an example is Impassion 030 that taught us that adjuvant atezo didn't add to chemo. Another study, ABRAVE, negative trial looking at adjuvant avelumab in TNBC. And so it makes you think that you need to have the tumor in place to really get the biggest bang for your buck out of the immunotherapy. So we all think most of the impact is driven by that preoperative component. So from an ethical standpoint, I think now that we have some data that has shown that adjuvant therapy isn't quite as good, and in fact, we have another smaller trial that just gave pre-op checkpoint without the adjuvant component, and the data looked very much like Keynote 522, it makes us think that that adjuvant component may not be so necessary. And so it's easier now to think about randomizing patients. I think ethically, we feel a little bit more equipoise, but we tend to always start with the lower risk patients when we de-escalate, and that's why we started with the PCR patients. I think it can be done in residual disease, and in fact, there is one enrolling trial now that does not utilize a checkpoint inhibitor in one of the arms for the residual disease population, TROPION-Breast03. But truthfully, it won't address this question because it's not mandating everyone had pre-op checkpoint. So, it's just, and it's hard. These trials are, over 1,000 patients. They take years to do. The standard of care evolves. So while I think it's still ethical, I just don't know how practice changing it will be in the long run.
Makes sense. And I'd be curious, and this might apply more from the lung setting, and Dr. Grivas, just chime right in if you have a comment as well, please.
No, I agree with Dr. Tolaney. I think this is a great discussion, and it's interesting to see the similar features and some differences across tumor types. I think that I was intrigued, Dr. Tolaney, to see the discussion that Dr. Koch did, and my discussion was similar questions we raised, just showing that this persists across tumor types. A couple of thoughts on the bladder cancer topic. Yeah. I would say that we have so far 3 purely adjuvant trials. One with adjuvant atezo versus observation. This was negative, did not show benefit in the adjuvant setting. On the contrary, adjuvant anti-PD-1, nivolumab versus placebo, and pembro versus observation. Those trials showed disease-free survival benefit in the purely adjuvant setting. So we have seen that, and we're still waiting for OS data in those trials. We just published in the Ambassador with adjuvant pembro versus observation at the New England Journal of Medicine last week, and we have DFS. It's almost the median DFS is doubled. The OS is immature, and it's not ready. But if you look at the curves, are on top of each other. So Again, you don't quote me, but I think it's unlikely to show OS benefit, being one of the investigators. But we're still waiting for the OS for the adjuvant nivo. Obviously, a big confounder here is in access subsequent therapies. But where I'm going with this discussion is we already have that hint of DFS benefit with adjuvant PD-1 inhibitor in bladder cancer. If you look at the PathCR, which is we don't know if it's a surrogate for neoadjuvant immunotherapy-based treatment. We know it seems to be a surrogate in neoadjuvant chemotherapy in bladder cancer. That there was a delta of about 10%, 37% with chemo-durva, 27% with chemo alone. And one of my, thoughts in the discussion was this delta of 10% personally doesn't convince me it explains the EFS and OS benefit, hinting, again, hypothesis generating, hand waving that we need the adjuvant component. Having said that, to Dr. Tolaney's point, I think we have a lot of theoretical arguments why neoadjuvant is relevant. You have the tumor present, the neoantigen is present, is visible, maybe in more quantities, right, than adjuvant. You have an intact lymphatic system before cystectomy and lymph node dissection. And we have seen data in other tumor types, breast cancer, lung cancer, with the neoadjuvant approach. And the other thing that I was reading about was the NADINA trial in melanoma. That was a very interesting study. I'm glad they did that, and others can comment. That they look at neoadjuvant immunotherapy versus adjuvant in the melanoma cancer type, and they showed that neoadjuvant was better, and they had the path states kind of adaptive adjuvant therapy. So there are definitely lessons learned, for me, from other tumor types. And again, there are some at least theoretical compelling reasons why neoadjuvant may make sense to start with.
I wish we had done those studies in lung, exactly like the melanoma trial. When we had the opportunity, a group gets neoadjuvant, a group gets. I think forgetting about the numbers and percentages and all that. And in lung, we're trying to do the same thing as you just mentioned, Petros. That we're trying to isolate the component of the adjuvant versus neoadjuvant, and it does look like the peri-operative sandwich approach does seem to be a little bit better, but it's all retrospective and a lot of methodological issues and all that. So I think if we had biomarkers and if we had a reliable MRD ctDNA assay in the world of lung cancer, you could have come up with study designs where you can use the biomarker to try to escalate or de-escalate certain groups of patients to receive specific treatments. Even as inadequate as the MRD assays are in the world of lung cancer right now, when you look at all of the data that's coming out, patients who have a path response and no detectable disease by a blood-based platform have better outcomes in terms of event-free survival, whether they got chemo alone or they got chemoimmunotherapy, sort of suggesting that the biology of the disease is more important than anything else, except that with the immunotherapy, you're helping that biology and you're pushing it towards having a better outcome. If you can apply those kinds of assays to at least patients with a complete pathologic response and sort of decide whether you can do randomized studies in two separate groups, ctDNA positive, ctDNA negative, I think you can start having answers. But as Dr. Tolaney suggested, these studies are going to take a long time. I can guarantee you that I'll be retired before any of that study is ever reported. But I think from my perspective, in the US, it's nearly impossible to do a placebo-controlled study, especially in patients with less than a path CR, because even as a physician, I might not feel comfortable offering that to a patient who comes in where I know the outcomes might not be quite as good. So I don't know if we have an opportunity again in lung cancer to do like a placebo-controlled arm for the adjuvant component after perioperative treatment. So I think it's going to be a little bit difficult. But using biomarkers, using, again, an MRD-based assay, I think might be helpful in sort of defining who can get a de-escalation versus who needs to have the treatment escalated.
And curious on the perspectives of, obviously we've been talking a lot about the checkpoint inhibitors, immunotherapy. Is there any difference when you think about targeted therapies? Kind of curious, maybe Dr. Borghaei, if we go to the EGFR setting or even the ALK setting, is there a distinction of, needing to have that tumor up front in the neoadjuvant versus adjuvant piece? Does some of this contribution to part story play through when we look at some of the more targeted therapies as well?
Well, at least in lung, the targeted therapies seem to be more in a post-op setting, suggesting that there, in fact, is a significant overall survival advantage. So if you take the ADAURA study with a limited time on osimertinib post-surgery with or without chemotherapy, not only was sort of the event-free survival better, but the survival seems to be better and extending even to an earlier stage of disease. So at least for patients with an EGFR or the conventional EGFR mutations, I think the preference is to use the targeted therapy in the adjuvant setting. Same thing with the ELINA. Again, in the adjuvant setting, there does seem to be a benefit. Obviously, for some of us, the controversy is whether we need the 4 cycles of platinum doublet chemotherapy or not, because these were global studies, and at least in ADAURA, some patients had chemo and some didn't. And the clinical efficacy didn't seem to matter in terms of the overall patient population, although some details are still missing. And in the alectinib study, in the adjuvant setting, it was simply alectinib versus chemo, so there was no chemo component there. But minor that, besides that issue of not having platinum doublet, I think at least at this point, my preference is to use these targeted agents more in the adjuvant setting. Not exactly the same, but we also saw the results of the LAURA trial at ASCO. Patients with stage 3 unresectable small cell lung cancer, EGFR mutation, post-chemo RT. And that study indefinite use of osimertinib was significantly better in terms of PFS in a patient population that got the osimertinib. So again, the bulk of the data we have in the world of lung cancer in patients with actionable mutation, these does seem to suggest coming in after primary treatment might be effective. So that is the way I think we're going forward with this. Now, the question of presence of the tumor, whether that matters and all that, I think it's a little bit more nuanced. And at least I think I need more data before I can give you a valid opinion as to how things are. But the targeted therapy group for us is just a little bit different right now.
Yeah. And Dr. Tolaney, curious, when we pivot into the HR positive segment, right? Whether it's, for patients who are BRCA receiving a PARP or potentially the Natalie and Monarchy studies from the CDK4/6, are there any kind of parallels or lessons learned there, or differences rather than what we start thinking about, the checkpoints in this perioperative setting?
I guess in my mind, I've framed it differently because I have thought of immunotherapy sort of having a different relationship by its mechanism of action. And that maybe biologically seems to make sense that it may matter that the tumor is still there. Whereas with targeted agents, we still have micrometastatic disease and it seems to be sufficient to utilize in the adjuvant setting. It's been harder in breast cancer, at least in HR positive disease, as you're mentioning. Most of our therapies have been in pure adjuvant trials like Monarchy, Natalie,
Yep.
Olympia, et cetera. And they're also longer duration exposures, right? 3 years of therapy in Natalie, 2 in Monarchy, a year in with olaparib. So they're not really studies that were designed to be started in the preoperative setting. Those
That's fair.
patients mostly got chemo. So my gut is I think the relationship is different, but we don't have any randomized data assessing pre-op versus post-op.
Yeah, no, absolutely. And kind of be curious to hear from each of you around, what are you kind of most excited about within your respective tumors, right? Or what are some of those kind of key things that are coming forward, whether it be post ESMO or things that you're working on now?
There is actually quite a lot happening in the world of lung cancer. And, the one area that I'm beginning to see a lot more excitement, a lot more research, an area where we desperately need it in the world of small cell, which basically has been an ignored disease for many, many years. And now we're beginning to see quite a number of clinical trials with some novel antibody drug conjugates, the bispecific T-cell engagers, the whole use of IO in limited stage disease, again, as per the presentation at ASCO for the Adriatic study. It does appear, and biomarker-based studies in small cell, which is fantastic to see. So we're beginning to see a lot of movement in that disease, and it really is an area of significant unmet need. In the world of non-small cell lung cancer, I am very excited about all the data in the perioperative stage. Again, we're hoping that there's going to be more and more uptake of lung cancer screening all over the country, although we're not doing all that well yet, but hopefully we'll get there. And that would probably mean more patients who might be surgical candidates. So improvement in that area can actually be one thing that in the next decade or so will lead to improvement in overall survival of patients with lung cancer or the surgically resectable disease. And that is hugely impactful and very significant for the world of lung cancer and patients who suffer from it. So that I cannot overemphasize how important it is to have these kinds of studies that show hopefully improvement in not only just event-free survival, but eventually overall survival. I mean, that is going to be a big patient population. In a metastatic setting in lung cancer, if you do not sort of include patients with actionable alterations, we've hit a little bit of a plateau in the use of checkpoint inhibitors in that we've not been able to overcome docetaxel as best second-line treatment, which is amazing, but all the stuff that we have cannot beat docetaxel. So what is it that we're doing wrong? Why cannot we be a little bit more specific about the patient populations? But, a hint of sort of hope was presented at World Lung with a bispecific antibody targeting PD-1 and VEGF based on studies done ex-US and mostly in China, indicating that perhaps some of these bispecific antibodies, because of the mechanism of action of the drug, could offer additional hope and benefit in a metastatic setting. So we're looking forward to additional information on the particular bispecific antibodies. I'm going to stop there and let my colleagues jump in.
Yeah, and please jump in. As I think about it, and as you're speaking, right, the question that kind of also naturally comes to mind, as we're seeing these therapies move earlier, does that then open up an increased unmet need in the frontline or even second line setting? And are some of these new therapies coming in to address that? Be kind of curious to hear each of your perspectives as well, Dr. Tolaney and Grivas.
I think in breast cancer, one of the areas I think that has been exciting are the antibody drug conjugates. And moving these drugs into the early disease setting is certainly ongoing. Both in the preoperative setting, we're trying to use ADCs, maybe trying to replace some or part of standard chemo. And also in the residual disease setting, lots of studies now ongoing with ADCs. And so, we've also seen CDK move into the early disease setting. We've seen PARP move into the early disease setting, checkpoint. And so I think you're right that one of the conundrums we're starting to see as patients are just starting to recur after getting some of these newer therapies, we don't really understand how now to approach those patients, because none of our first line trials really dealt with that, right? What do you do if someone recurs after getting an adjuvant CDK4/6? Well, I don't know, because normally we give a CDK4/6 first line. What do you do if someone got pre-op checkpoint? Are you going to give them checkpoint again? Does it matter what the disease-free interval? What was the resistance mechanism, right? All these questions are starting to emerge, and we're just starting to think about how to design trials to address that. And I think we also don't really understand the biological changes that have occurred in these people who are recurring after adjuvant therapy. I'll just say one anecdote is our group just pulled a very small group of patients who relapsed after adjuvant CDK4/6, and a tiny subgroup. But it turned out half of them lost ER expression. And, are there biology changes that are different? And that means therapies are going to need to be different. So I think we just have a lot to learn for how to approach these people.
I try to go last so I can learn from my colleagues, Dr. Tolaney, Dr. Borghaei here. So I agree that this is such an exciting time to be in oncology for all the reasons that were discussed. And you're right that we're trying to move along, treatments from metastatic disease to localized disease, and by doing that, I think we're curing more patients, and that's the most exciting thing. I can share with you that we see patients, more of them being disease-free, recurrence-free, at least for a long time. And I think we can definitely say that we cured them, especially in localized disease. And to expand on that thought of cure, I was part of this press conference panel during ESMO, and we had colleagues across different types: melanoma, breast cancer, lung cancer, and one of the journalists asks, "Are we curing patients with metastatic disease? Can we say that now?" And it was a great discussion because my take. I want to hear what you guys think. My thing is, I think yes. I think we're starting to cure patients. We see that, and at least we see long-term remission for years with no recurrence. And do we call this cure? Possibly. The challenge is on the individual patient level. It's hard to predict individual and say you are cured. We cannot say that, right? So we still have to do surveillance, and we probably less frequently. And we go to 5-10 years, maybe less frequently. Depending on the cancer type, right? In ER-positive breast cancer, I think you see late recurrences more often that you see in urothelial sometimes, but. It's definitely, I think, overall in the population level, we cure more patients, and we will keep curing more patients. And with new modalities, of course, antibody drug conjugates, combinations, right? Definitely ADC plus checkpoint inhibition seems to be the most successful strategy in metastatic urothelial carcinoma. Now we see response rates about 70% with pembrolizumab plus enfortumab. How can we build upon that? That's a high bar. The doubling of median overall survival. It's great. How do you expand on this? And we're trying to figure it out. We have similar questions that Dr. Tolaney mentioned in bladder cancer, a challenge with the same agent. And actually, we had an educational session at ESMO asking this question, and we had some of the experts talk about it, and the data are not that much about rechallenge and how long do you give an agent, duration of therapy, de-escalation. Again, someone has progression after adjuvant nivolumab, how long treatment free interval, how long is enough to give checkpoint inhibitor again? These are very good problems to have in terms of having more options for the patients, but they represent challenges in the clinic for sure. I think that the last two comments for bladder cancer, I see bladder preservation will keep increasing its frequency, will keep becoming more common, and there are so many let's say, settings for bladder preservation. The most common is the classical trimodality therapy with maximum TURBT followed by concurrent chemoradiation. And we're trying to build upon that by asking the question to add a checkpoint inhibitor. And we have 2 phase 3 trials ongoing there. But in the future, I think the big question we're going to face is, can we cure patients with systemic therapy alone? Can we get that good with effective systemic therapies, with combinations, and potentially some biomarkers with clinical utility to help us select patients who we think we cured with systemic therapy alone? We're not there yet, I think, but we're heading there. Yeah. There's some early phase 2 data in that direction.
I mean, the only thing I want to bring up, and I agree with both Dr. Tolaney and Dr. Grivas, and I'm never going to disagree with either one of them, but I think unless we figure out who really benefits from a particular drug or who doesn't really benefit from it, we're not going to make the kind of improvements that we want to see. We all acknowledge the checkpoint inhibitors, at least in the world of lung cancer, to some extent bladder, have been fantastic, and to maybe to same extent in the world of breast cancer. There's no question about that. Are we curing patients with metastatic disease? I believe that, yes, we are in the world of lung cancer, particularly because after 3-4 years, we don't call it the same lung cancer. We say it's a new cancer. So unfortunately, that can happen. But I think as oncologists, and the entire field has to get away from giving platinum doublet chemo to everybody who walks into the door, and then platinum doublet chemo plus the next wonderful drug, and then the next wonderful drug, and then going to quadruple therapy and 6 drugs. I think this is not a way to manage these sorts of diseases. I think we have to learn what's the role of sequential therapy, who would benefit or not benefit from particular treatments. All of our treatments have long-term toxicities associated with them. Are we paying attention to that? I think as a field, and it's very difficult in my view to do biomarker work. I have a lot of respect for investigators who do biomarker research. It's very difficult, but I think we owe it to our patients and to ourselves to try to be a little bit more selective and try to figure out how are we going to deal with all of these antibody-drug conjugates, bispecifics, T-cell engagers, who's going to get what, how. We're not addressing any of that. And I think it is our job to try to push the field in that direction.
Yeah, no, absolutely. And then I think it'll be kind of very interesting to hear across the board, probably kind of some of the recent perspectives on TROP2s, right? Obviously kind of with ADCs making an impact across all of oncology and seeing some variability in results, I think that kind of might feed into your discussion here a little bit, Dr. Borghaei, on, what is the right biomarker for these therapies and how this kind of impacting some of your day-to-day clinical practice.
Well, I think, at least in my field, the TROP2 antibody-drug conjugates have not been, let's say, quite as impactful as we wanted them to be. At least 2 of them have been tested, and there's additional EDC. So a hint of, hope came at the World Lung, where a new method of detecting TROP2 was reported with this NMR, which I think is fascinating, using AI technology, trying to predict. And, again, it's something that has to be validated, and additional information is desperately needed. But it seems that this new method of measuring cytoplasmic TROP2 versus cell-bound TROP2 might be a way forward in identifying potentially patients who would benefit from the ADC. And that's really wonderful to see that, a big company is actually spending time and effort into trying to figure out what the biomarker might be. Case in point, the TROP2 ADCs, come with potential toxicities. And if the only thing we can get out of them are improvements in progression-free survival, given the degree of toxicities, I think, again, it would be nice to be able to identify who really is going to need that drug or can benefit from it, as opposed to this blanket approach that anybody should in the second line, third line setting get these drugs. So I think that kind of a biomarker research is more needed. And again, I think for specifically TROP2, if we can validate the biomarker that was presented at World Lung, I'll be very happy to use that in a clinical setting and decide how to choose patients for these specific treatments.
And just to comment, this is a great discussion. And, I was talking to a good friend of mine who's in MD Anderson, Dr. Sowell, the other day. He's a medical oncologist, GU, focused on kidney cancer. He's also one of those people who loves biostatistics, and he has learned, kind of self-taught, and he now understands all these biostatistics concepts very well. So I'm trying to pay attention when he talks so I can understand the concept. And he was telling me that, to Dr. Borghai's point, predictive biomarkers, which are so important, are so hard to validate and confirm the utility, and you need like a gigantic the sample sizes, like usually 16 times of what we do in clinic to have enough power to validate a predictive biomarker. Prognostic are probably lower bar, but it just shows how hard it is, and probably that's why, at least in bladder cancer, we have not had major successes with predictive biomarkers. We always think we got it, and the subsequent trials, like PD-L1 or others come to mind. So I think I agree 100%. We still need to pursue those predictive biomarkers, and maybe, who knows, in the future, big data, AI can enable us to synthesize data sets and have like enough power to identify some of those.
I will say, at least in the breast world, I keep hoping that we will have a biomarker to help us. You mentioned TROP2 ADCs, to figure out, one, in breast cancer, maybe how to sequence ADCs, because we do have sacituzumab govitecan both in triple negative and ER positive disease. Dato-DXd, we'll see what happens with HR positive disease, and we'll see what data emerges in triple negative. But we also have TDXd. And so it seemed like TDXD's efficacy, at least in a recent analysis, suggested that the more strongly HER2 driven you are, the hazard ratio seemed to be stronger in DB06. And it made me wonder, well, maybe if it's super low HER2 expression and you had super high TROP2 expression, maybe you'd think, oh, I'll use a TROP2 ADC first and save the HER2 guy for later, or vice versa, depending on target expression. But as was pointed out, we haven't seen great data that target expression is generally predicting benefit. Like with sacituzumab, we can't say that, we don't need to test for TROP2 right now. Again, maybe that will change as we have different methodologies for looking at target expression, different quantitative measures, maybe more AI technology to read these things. So I think, we'll have to see how this evolves, but these biomarkers are tough. And it's true that we are struggling a bit with them right now.
I think we got a little bit spoiled. At least I did. We have EGFR mutation. You do X and everything is great. You have an ACT, you do X and everything is great. And then PD-L1 comes and says, over 50%, you do pretty well. So we got spoiled. Now we expect every biomarker to be, binary. You either do great or you don't benefit, and we're done. But the reality is that most biomarkers aren't like that.
I agree. I think you guys in lung cancer are leading the field with biomarker work, and we're learning from you. And it's interesting. We're trying to put a grant together with my team here at Fred Hutchinson UW and looking at tumor heterogeneity in bladder cancer, and it's such a heterogeneous disease. And even we published a manuscript a couple of years ago looking at different metastases and the clonal evolution. It's just scary to see how quickly it evolves, and it's probably part of your points that just hard to to have a reliable biomarker. But I think it's definitely worth keep up the effort. And actually, we have just FYI to share with the group. We have a rapid autopsy program available for patients here, and I know it's a very a lot of resources to sustain it, but we try to keep it alive because it's so important to learn. It's amazing how patients find value and meaning to contribute, and they sign consent before they pass for that. So hopefully we'll get more information for tumor heterogeneity and biomarker discovery.
Well, Dr. Grivas, I have to say, if anybody can find a biomarker in bladder, is you. And we're holding you personally. You and Dr. Plemek here at Talkshows, I think we have the greatest hope for you guys to find biomarkers in bladder.
You're very kind. You're very kind, Dr. Borghaei. It's a great team effort, and learning every day.
No, this is fantastic, and I know we're kind of coming near the end of the hour here. would be kind of great to hear any kind of, obviously there's been discussion around how do we think about neoadjuvant to adjuvant contribution of parts, different treatment settings, and I think the key importance of biomarkers. Great to hear, what you're looking forward to the most, and, let's just say in the next 6 months. And I think one of the core questions that also kind of comes to mind a little bit, I know we've touched on a bit, is, beyond the biomarker, are there other endpoints that you're thinking of looking at, within some of these more peri-operative treatment settings that might be helpful? And there's a lot of debate around PCR, EFS as well, but kind of curious to hear any final thoughts from each of you. I don't know if Dr. Tolaney, you want to go first, and then we can pass it around.
I mean, I think in breast cancer, at least in triple negative and HER2 positive disease, PCR has been helpful to understand who's going to do better versus worse if you have residual disease, but obviously not perfect. Certainly PCR patients can relapse, residual disease patients can be cured. It doesn't correlate perfectly. And so I think we are thinking about how to figure out, even if someone has a PCR, for example, who's going to recur, or if someone has residual disease who may be cured and not need additional therapy. Obviously, one potential thing to think about is MRD, to incorporate both response to therapy with MRD to help tailor. But as has been pointed out earlier, I think at least in breast cancer, our MRD assays are not quite perfect at this point in time. In fact, some studies have suggested when we found MRD, at least in triple negative disease, a large proportion of patients already had metastatic disease. So it wasn't really MRD. In fact, we were finding metastatic disease. And so, it was too late, in essence, to try to intervene to prevent that recurrence. And so we need assays that are more sensitive. And same in the PCR setting, we're not detecting everyone who may have minimal residual disease. Our assays aren't sensitive enough. And so we're getting there. And I think things will change. And just right now, we're not there yet. I think we're going to have to integrate a lot of information, maybe baseline clinical anatomic information, gene expression data, response to therapy, MRD presence, right? It'll be probably AI giving us a multifactorial prediction model. I don't think it's going to be one answer.
I can go next, and it's again amazing how much common questions, mutual questions we have across tumor types, and it's actually interesting. Just a few minutes before I logged in, and I was getting these calls, I saw an email coming about a webinar of lessons learned from other cancers to bladder cancer. So I might invite all of you to help me with that. So I think the pathologic complete response, at least in bladder cancer, over the years has been associated with long-term survival, at least with neoadjuvant chemotherapy. It's hard, of course, on the individual patient level, and there are many factors, as Dr. Tolaney discussed, response to neoadjuvant chemo, pathologic states, and maybe ctDNA, MRD that can help us, prognosticate that patient, at least for now, at least this. And the prognostic biomarker has value. We know that from Oncotype DX, right? In breast cancer, it's a prognostic biomarker with huge value clinically, help decision making. So I think all of those factors can help inform those prognosis and indirectly decision making. I think in the context of immunotherapy, we need more follow-up to adjudicate and ascertain whether PathCR correlates with long-term survival. And I think that's, the follow-up will help us answer this question. I think it's interesting to also think about MRD. So far, at least in the early days of MRD in bladder cancer, there seems to be a lag time between about 3 months, give or take, between ctDNA positivity, conversion to positivity, and disease noted on scans. And the question is that a clinically meaningful interval? Does it make a difference if 3 months later? I simplified, of course, but is it clinically useful? And we have not answered this question either, right? And is that going to answer to create more anxiety? To Dr. Borghai's point, is it like meaningful to the patient outcome? I think we need to answer those questions for sure, and not only in the contents of the adjuvant decision, but also metastatic disease. And the last thing I would think about is, as we get better again with systemic therapies and hopefully we're curing more patients, how can we become better in trials, including ours? And I put myself in that too, to try to measure more patient-reported outcomes in trials with, ideally validated tools. And it's hard because each disease type may have different quality of life metrics, and it's hard to capture those, greatly, in individual disease state or type. And also, of course, think about, the burden, to the patient themselves, how to measure that, and things like, cost of care, which is another very difficult to measure and a very, very difficult discussion, of course. But all those parameters probably become more and more important as our patients live longer, which is great. We're going to face with those questions as we go forward.
I don't think I have any, newer perspective beyond what my colleagues have already expressed. I think your primary question was, are there any other endpoints that we can necessarily look at? And, biological endpoints have always been of interest, as opposed to that old-fashioned PFS, OS, or landmark analyses. But again, as we discussed, as is the case in biomarker research, it's been difficult to come up with these biologically meaningful endpoints. In the world of lung cancer, if you go back 20, 30 years and look at the old, what we used to call Pancoast tumor, the superior sulcus tumors with chemoradiation, patients with complete pathologic response after chemoradiation when they went to surgery did better in terms of overall survival. So prognostically, that's what we had used, but it never became an endpoint validated in randomized phase 3 studies for us to use as a potential drug approval or anything like that. So now we're facing those kinds of difficulties and situations in these sort of peri-operative studies that are being conducted. So I cannot tell you if we have any newer endpoints that we would like to see.
Right.
But we're using all of the tools that my colleagues mentioned, AI and MRD assay and tumor-informed and things like that, to try to see if we can get to a place where, the studies can be a little bit more meaningful and more informative.
Excellent. Well, I know we're at the top of the hour, I guess the bottom of the hour, depending on how we look at it. But I want to thank each of you doctors so much. I think it's been a very engaged discussion. Kind of great to hear different perspectives, from lung for you, Dr. Borghaei, with breast cancer, Dr. Tolaney, and kind of rounding us out, Dr. Grivas, from a bladder perspective. So thank you very much to each of you, and we look forward to partnering again soon on another roundtable in the future.
Thank you, everyone.
Excellent. Take care.
Good evening. Bye.
Thank you so much. Amazing discussion.